will be recorded here. So I already had at least a handful who have asked for the recorded version, so we'll share that afterwards. And if you have a question along the line, please write them in the chat, and then we will take them at the very end for a short Q&A session. But I think the first 20-25 minutes is for you, Juan, who will take us through some of the latest advances within AI and biomarkers for digital pathology. So I'll hand it over to you to introduce yourself. Thanks for joining.
Perfect. Yes, thank you. Thank you so very much, Ulrich. So let me just share my screen. So if you could just give me a heads up that you can see my screen properly. Is that showing for you?
Yeah, we see it now. Great.
Great, perfect. Okay, very good. So, so my name is Juan Retamero. I'm an anatomical pathologist, and essentially I joined Paige about 3 years ago. Essentially, my background is in the implementation of digital pathology and AI for routine clinical use. So that is in a nutshell who I am. Now, who I am not is basically I am not a molecular geneticist. I am not a molecular pathologist, and I think that will obviously become clear as we go through the presentation. But essentially, just to set the scene and to start discussing some key concepts that I think is important to discuss right off the bat, is essentially the relationship between genotype and phenotype, which is obviously very important in molecular biology. So obviously, by genotype, what we mean is the genome of an individual, both at an individual level, but also at the tumor level. And normally speaking, that genotype is what's going to essentially define the phenotype. In other words, the aspect of that individual. Again, this applies both at the individual level, but also in tumor biology. Thing is that the genotype is not always 100% expressed. And the reason for that is that, factors like the environment, epigenetic factors, and other genomic factors actually modulate how that genotype is actually expressed on the phenotype. So this is very important to understand, because at the end of the day, what we're interested in is mostly on the phenotype. So the aspect of the cell that would render it subject to therapeutic agents that may be prescribed by the oncologist. Again, when we do molecular testing on a tumor level, what we're looking at the end of the day is the genotype. However, what digital pathology and AI actually do is reveal aspects of its phenotype, of its morphology, that could be of significant importance when it comes to render that tumor subject to certain therapeutic agents. So in other words, a mutation may be present on the genotypic level, but that mutation may have been muted for a number of reasons, ranging from environmental reasons to other genetic interactions with different genes. Of course, epigenetic factors may have rendered that mutation essentially not expressed on a phenotypical level, and hence that cell population would not be subject to be treated with a certain therapeutic agent. I think essentially that this concept was laid out by Juan Rosai, almost a quarter of a century ago. So essentially what Dr. Rosai proposed back in the day is that the morphological appearance that we see on a tumor, when we look at it under the microscope, is at the end of the day, the synthesis of thousands of genes that are actually manifested and result in that morphological change. And that, those with the training and the ability to detect it could actually predict that morphologic and that phenotypic and that genotypic change associated to that morphology. So again, a certain molecular status can be associated with a certain phenotype. The phenotype can be detected by digital pathology and AI, which is essentially what we'll discuss later on today. And again, very important to bear in mind that only the tumors that express that phenotype are amenable to those therapeutic agents. Very important to bear this in mind going forward. Now, switching gears, how can you train an AI? Essentially, there's many ways of training an AI, but generally speaking, in pathology, there's two main approaches. One of them, which is what we see on the left-hand side, essentially involves a pathologist drawing a certain region of interest in a screen to essentially tell the machine that this yellow area is what a tumor looks like, and this is what the machines should learn. Generally speaking, this is not how we train AI models at Paige. We do follow, however, the approach that you see here on the right-hand side, which essentially couples the entire histological image, the digitized version of the glasses slide, together with the pathology report, and of course, in cases of molecular biomarker development, with the corresponding molecular report. And the beauty of this is that essentially we're not telling the machine what to look for. Obviously, when we draw circles around regions of interest, like we do see here, we're introducing biases. Pathologists are normally trained to look at the epithelial component and, in so many aspects, disregard comparatively the stromal component. And of course, we know that the stromal component has ever greater importance. Long story short is that perhaps the better way to train an AI at scale, obviously for generalizability purposes, would be to follow a weakly supervised approach, as we see here on the right-hand side of the screen. And essentially, this approach permits a significant expansion in the data sets used to train an algorithm. Obviously, having a pathologist doing circles around regions of interest puts a significant bottleneck in how many of these slides actually can be annotated, and therefore renders these data sets much more smaller than those data sets that are actually used when training an algorithm with weakly supervised approach, as we discussed earlier. But of course, the question is, right, can we actually really train an AI with this weakly supervised approach? And can these models be actually of use in clinical practice? So this is the question that our groups essentially set out to answer about 3-4 years ago. And essentially the answer is what you can see on the screen, that a model trained with this weakly supervised approach could indeed achieve very high diagnostic performance, very high areas under the curve in different tumor types, ranging from prostate, basal cell carcinoma of the skin, breast cancer metastasis, lymph node, etc., etc., etc. So in other words, yes, you can train a model with weakly supervised approach, and the model can indeed learn to differentiate fairly well all of these tumor types. And again, this is something that we published in Nature Medicine about 3-4 years ago. So definitely well worth a read, in my opinion. So with that in mind, obviously, a lot of water has gone under the bridge ever since that study was published. And here we can see comparatively the size of the data sets that have gone in training all of these models in comparison to that paper, that Nature Medicine paper, and how different models have been trained using increasingly large data sets. So for instance, here we see the data set that was used to train Paige prostate, which to date is the only FDA-approved solution in pathology, was 60,000, which, let's say, well, it's starting to pale in comparison to the massive data sets that we are actually using today to train foundation models. And essentially, foundation models are here to revolutionize the realm of computational pathology, because these foundation models are actually showing evidence of doing even a better job at classifying tumor and detecting tumor from the clinical aspect, even in histological variants that can be very rare, very exceedingly difficult to diagnose by a model. We can see that how foundation models are actually doing a much better job in that regard, but also are being very helpful in detecting biomarker status in tumor. Of course, the amount of computational power required to essentially process millions and millions of slides requires, very strong partnerships with key players like Microsoft that otherwise would render this endeavor much more challenging. And essentially, this is how the Virchow Foundation model was born. So, obviously, we call it Virchow in honor of the father of the profession of pathology. But essentially, it's a pan-cancer model that has been trained both in resections and biopsy specimens from many different topographies that you can see here, and encompassing up to 1.5 million of slides, as you can see here, all the way back to 1.2 million blocks from thousands and thousands of specimens coming from almost 120,000 people. So again, this gives you an idea of how the scale of data has been progressing in the last decade when it comes to the development of artificial intelligence models in pathology. And essentially, the role of the foundation model, or the way that in which it works, is essentially to capture out of a digitized H&E slide. The idea is to capture only those areas that have tissue and to break this tissue in little tiles measuring 224 squares. From that, the model is actually passed and reads each one of these tiles, and then Virchow generates a little embedding for each one of these tiles. An embedding is a vector, is a mathematical representation of all the information contained in that tile. And then an aggregator model, which is another AI model, essentially summarizes all of these vectors and provides an output for the slide level prediction. And again, this can be actually, this approach can be used to both cancer detection, but also histological subtyping, as well as the prediction of the biomarker status for that particular tumor. And in this slide, what we can see is the performance of the Virchow model in actually detecting all of these types of tumor in different biopsy specimens. So as you can see, very high area under the curve performance, generally maximized for sensitivity in order to operate as a screening tool. So as you can see, Virchow, a foundation model, can actually do a very good job when it comes to detecting cancer for all of these topographies in biopsy specimens. Right, but today we're here to talk about biomarkers. And the first biomarker that we're going to talk about is the detection of HER2 status in breast cancer. So generally speaking, when it comes to the normal segmentation of the breast cancer patient population, especially a hormonal receptor positive subgroup of breast cancer patients, the traditional paradigm is that only 15% of those patients actually show HER2 amplification. And these were the subgroup that would actually go on to receive hormonal therapy in the form of, generally speaking, trastuzumab and related drugs. But of course, the paradigm has started to change over the last couple of years with the advent of antibody drug conjugates, which essentially is trastuzumab together with a molecule of deruxtecan. So essentially, what we do not know now is that these patients that have low HER2 levels can actually be given this new class of molecules, and they would actually clinically respond to those. But even more than that, we know that there is a very small subgroup of patients that have undetectable HER2 levels that actually respond to these drugs, which seems to be not in agreement, not in concordance with the current paradigm. And in fact, the hypothesis that we have here is that a small subgroup of these patients that would be HER2 negative, in reality, what happens is that they express some levels of mRNA for the HER2 receptor, which in fact renders them subject to respond to the new antibody drug conjugates. So essentially, the hypothesis that we wanted to test was whether we could train an AI to detect and to help us differentiate patients that will not present those levels of mRNA for the HER2 receptor from those that will have. Because at the end of the day, the current companion assays that we have in terms of immunohistochemistry, in terms of FISH, essentially they are geared to separate essentially the very positive end of the spectrum, but not so much the negative end of the spectrum, because of course the paradigm was geared to identify those patients, but not so much these patients here, because there was no therapeutic alternative for them. But of course, this has changed now. So the idea again was to try and identify those patients that have essentially HER2 negative status defined by the number, or rather the amount of mRNA for the HER2 receptor, from those patients that have some mRNA expression and therefore could be liable to benefit from the new molecular being offered. So essentially, the way that we trained the algorithm was following the multiple instance learning that we mentioned earlier. And the idea was to provide a binary classification. It's either HER2 negative or HER2 low and above. So essentially binary detector that will tell us whether that patient will be likely to benefit from the new therapies or not. And essentially the ground truth was set based on a level of mRNA below 7.6. So those patients would be called negative. And this was determined via Oncotype DX HER2 specific score. Those patients who would actually have an mRNA level above 9 on the same test would then be called HER2 low or above, basically. But again, the idea was to essentially train an algorithm that would help us differentiate from these two groups that we see here. And this is essentially the performance of the algorithm. So as we can see, the area under the curve is quite significant, 0.91%, with a specificity of 99% and a positive predictive value approaching 96%. So essentially what that means is that if the algorithm tells me that this patient is negative for HER2, the negative predictive value, in other words, the chances that that negative result comes from a negative patient would be 92%. The flip side of the coin would be that the positive result essentially would mean that that patient has a 96% chance of actually presenting mRNA levels beyond the cutoff point that we mentioned earlier. So essentially, what we are seeing is a distribution which is similar to what we do see here in this graph. Let me just zoom in there for a moment so we can see what that means better. So essentially, what we are assessing is the level of mRNA expression. What we do see here is the normal distribution of patients that will be positive, generally speaking, for HER2 in immunohistochemistry. But we also see this subpopulation here, these yellow bars, that we believe in reality actually correspond to a tail of the patients that actually would be HER2 negative. So in other words, the patients that will not have sufficient levels of HER2 mRNA, HER2 mRNA, and therefore would not respond to the new antibody drug candidates. So that is essentially the idea that we found based on our validation tests. So obviously, a number of questions arise here. So what is the AI actually picking up? So yes, we know it picks morphology, but in reality, we do not know whether it's looking at nucleus to cytoplasm ratios, membrane shapes, etc., etc. The point is that we don't know what it is that the AI is picking up. But obviously, from a pragmatic point of view, the common question is, right, can AI replace immunohistochemistry here? And the point is that we do not see that happening. Indeed, what we do see is an adjunct use being artificial intelligence being used as a companion test to complement immunohistochemistry. So perhaps in those cases in which immuno is negative, but the AI is telling us that chances are that that patient is HER2 positive, perhaps what I might want to do is further molecular tests. Perhaps I want to show the case to a colleague. Perhaps I want to repeat the immunostaining there. Perhaps I want to use further artificial intelligence tools to help me better quantify the HER2 expression on that immunostain. So again, the idea here is to better classify patients and to better pick, this curve that we saw earlier, and better classify the yellow bars from the blue bars because they represent patients that may behave differently when exposed to that new medication. So what would happen in patients in which the immuno is negative, but the AI is deemed to be positive? Again, the idea is to use this as a companion test that essentially enhances one another. So additional testing, things like showing, the case to a colleague, use additional artificial intelligence tools to essentially corroborate that immunohistochemistry is 0, or perhaps do staining from a different block. And of course, an open question that we haven't tested yet is whether we can do this in patients with negative hormonal status. Bear in mind that the cohort that we have trained was essentially based on hormonal positive patients, but this hypothesis has not been tested in patients with negative hormonal status. Right, so moving on to MSI next. Okay, so again, main concepts, main principles around MSI and DMMR. So essentially, the DNA polymerase is, obviously the main enzyme that basically is in charge of replicating the DNA in humans. But we know that this enzyme is not perfect, and when it does its job, has a natural error rate. Thankfully, there is a cohort of genes, a cohort of proteins that actually encoded by these genes, whose job is basically to patch up and to mend the errors made by the DNA polymerase. So the idea is that all of these genes, when they function normally, they would actually patch up and fix all the errors made by the DNA polymerase. The problem is that in some status, for instance, in situations like Lynch syndrome, which is an inheritance, hereditary lack and deficit of these proteins, the function of repairing the errors made by the DNA polymerase is not as sharp, is not as good. And this leads to a loss it leads to a cumulative sequence of errors in the DNA, essentially due to the lack of these proteins. So essentially, this shows us instability in tandem repeat sequences, which is what we know as microsatellites. And that in itself obviously increases the chance that those cells will become cancerous. Generally speaking, the majority of MSI high patients are actually sporadic, but essentially there is also a subgroup of patients who present an inherited situation, which we call the Lynch syndrome, but also called as non-polyposis colorectal carcinoma, which essentially renders these patients far more likely to develop things like colon cancer, endometrial cancer, but also another series of several cancers, mainly in the GI tract, but also in other topographies in the body. And of course, these patients, because they will be subject to an increased cancer risk, they need to be screened, and their families will need to go for genetic counseling, etc., etc., etc. Also, generally speaking, patients with MSI high caused by DMMR tend to respond better to immunotherapy, to things like Keytruda, pembrolizumab, etc., etc., etc. So that is the reason why it is important to be able to detect these patients early. Those who have an inherited cause, obviously, to provide genetic counseling, which are the minority, and the majority of patients with MSI high would obviously be to see whether they can be subject to better immuno-oncology and essentially to Keytruda that is shown to have a better outcome when that medication is provided. And indeed, since 2017, there is a strong recommendation to screen in newly diagnosed colorectal and endometrial cancers for MSI high. But the problem is that despite these strong recommendations, the recent studies have shown that only between a quarter and less than 3/4 of these patients of new colorectal cancers are being properly screened. So in other words, we don't always do a perfect job when it comes to screening these patients, these new colorectal patients for MSI high. So the idea is, can we actually develop an unobtrusive screening tool that will help better screen and making sure that we detect better these patients that otherwise would actually sift through the net and will not receive the treatment that they actually require. So essentially, the solution goes around, the key concept of essentially tumors that are MSI high would have a distinct phenotypic look. So in other words, they look somewhat different to those tumors that are MSI stable. And we know that this is a fact actually in colorectal cancers. But the idea now is to extend this concept beyond colorectal cancers to endometrium and to stomach, and eventually to extend to all the tumor types, in many different locations, in order to make sure that we can screen a better percentage of the population for MSI high status. Obviously, another challenge here would be, so if we develop this tool that can actually just look at the tumor morphology and screen for MSI status, this tool should be seamlessly integrated in the diagnostic workflow, and certainly in a digital pathology environment provided by Paige that essentially ranges from the digital case creation to the diagnosis of the case, aided by the tumor detection. So in other words, another AI tool that would help detect whether cancer is present or not on a slight level. And if so, then the colon MSI algorithm would kick in to essentially screen this tumor detected by the previous algorithm for the MSI status. Now, assuming that the output of this AI tool actually is stable, then the patient would go straight for case sign out. But obviously, if the result is positive, then this patient obviously then should go for a downstream molecular testing or immunohistochemistry testing then to finalize the case. But the idea is that the screening tool is embedded within the diagnostic pathway. So in other words, so every single patient that gets diagnosed using the workflow would be detected, would be screened for potential MSI high status. Now, what does that tool actually look like and how does it work? So essentially, the tool, what it does is, again, a binary detector that tells you whether the phenotype is MSI high detected or not. So essentially, it's a binary detector that whenever MSI high phenotype is detected, will display this warning message on the screen. The performance of these screening tools is essentially what you can see here on the screen. So essentially, again, it's a tool that has been geared to maximize sensitivity and yielding an overall area under the curve of 0.95. The way in which we developed this tool was essentially using both immunohistochemistry together with NGS data from MSK. So in other words, orthogonal methods combining both immunohistochemistry together with molecular NGS data. So this is a tool that is available now, and essentially the performance in a colorectal cancer dataset comprising 300 cases yielded a negative predictive value of 99.5%. And this is a tool that has been validated both for biopsies, but also for resection specimens, including primary tumors, as well as metastatic tumors. At the moment, we are organizing clinical studies with some of our collaborators to essentially confirm the performance, but also the impact of these tools throughout the diagnostic workflow. So in other words, to assess the impact of these tools in downstream immunohistochemistry and molecular testing, including time and potential money saved here. Also, recently, we submitted this validation work comprising these 300 cases that we mentioned earlier to the CAP conference. And essentially, out of these 300 cases, the AI missed a sole case, one single case, that essentially was a liver metastasis that only contained small groups of cancer cells, and that was essentially missed by the AI. So essentially, a challenging case with very small, very low tumoral burden that was missed by the AI. Now, generally speaking, that's what, in this validation test, that's what a false negative looks like. False positives, on the other hand, they tend to look more like, the phenotype as typically associated with MSI high tumors, which essentially involves, tumors with mucin, with tumor infiltrating lymphocytes, or things that actually look like tumor infiltrating lymphocytes. Okay, what about expanding this screening tool beyond colon into other tissue types? So this is something that's going to be available very soon, within the next few days, for beta release, and of course, research use only. But as we can see here, the sensitivity, the diagnostic yield in endometrium and stomach are actually, pretty high. So certainly, again, not perfect, but certainly much better. And we believe much better aid in the screening of these patients, in which, generally speaking, we don't do a perfect job at screening. So the idea here, the rationale would be to make more cost-effective screening in some of these topographies for all of these patients that mostly go not properly screened. And the idea that obviously we pick up and detect many more of them. Right. And finally, what about non-small cell lung cancer? What can we do for these patients? So essentially, the idea that we had was to develop a molecular panel essentially geared to detect any of these mutations that you see here. So obviously, these are perhaps, the 5 most common mutations. So what we did was to develop essentially with the outputs provided by Virchow, essentially applied to almost 3,000 cancer sets. Essentially, what we did was to train it to detect any of these 5 mutations there. And again, this would be a binary detector. So if it tells you that it's negative, chances are that none of these mutations would be present. If it tells you that it's positive, chances are that at least one of these mutations would be present. So the idea would be to obviously create and expedite a very quick test that would tell you whether that tumor in particular is likely to be negative or likely to be positive for any of these mutations. If it's likely to be negative, the rationale, obviously, if the validation test and the prospective studies confirm the initial evidence, would be that in theory, these patients have a very, very low chance of presenting any of these mutations. And we know that because the negative predictive value of this test, based on the validation test that we've done, is 96%. So in other words, chances are that whenever the test tells you that this tumor is negative, it will actually come indeed from a negative tumor. However, if the model tells you that it is positive, then we know that at least one of these mutations will be positive and therefore would warrant further downstream molecular testing. Right, and the last model that I just wanted to discuss today would be another tool that actually predicts response to immuno-oncology in non-small cell lung cancer. So the idea would be whether Virchow could actually help us detect overall survival when it is above 42 months in patients treated with Keytruda. So in other words, is that tumor in particular being treated with Keytruda likely to go beyond an overall survival of 42 months or not likely to reach that target? So the model can basically differentiate between these two populations with an area under the curve performance of 0.75%. Right, so to start wrapping up my session, I do realize it is quite a bit to take in, but I think this man said it quite well almost a century and a half ago, that no matter how much we twist it and turn it, we always shall come back to the cell. So obviously in the time of molecular pathology, obviously molecular gained the spotlight, but as we delve deeper and we gain better insights into the correlations between genotype and phenotype, we do realize that molecular in itself is not the entire answer, of course. And of course, better integration of these molecular outputs with a corresponding morphology, we do believe that actually provide a much better service to our patients. So essentially, the idea would be to use artificial intelligence as an adjunct. And that's the key word here. This is not intended to replace current practice, but rather to enhance and to supplement current practice for all of the reasons that we have discussed. So with that, yes, I do realize it's quite a bit of information to take in. So I'd like to thank you all for your attention. And of course, if time permits, let's open the floor to any questions. Thank you.
Thank you, Juan. And please write questions in the chat if you like to ask Juan a question. But allow me to start with a few questions then. When you deploy this around the world, do you see any difference in the performance of the AI, whether it's in Asia, Europe, or the US, or is it robust and generalizable?
Yeah, so that's a very important question, because obviously AI, we do know that AI is extremely sensitive to differences in data. Bear in mind that these models have been trained in several thousand, if not millions of slides, many of them coming from multiple labs from around the world. So in other words, the model has been trained to be robust and to be generalizable. So the idea is that based on the initial evidence, of course, one has to be cautious here, but based on the current evidence, the models generalize pretty well. And by generalizing, what we mean is essentially the ability of the models to tolerate differences in stain, difference in pre-analytical variances, differences in tissue thickness, in tissue sectioning, difference in image format. And the initial evidence is that these models actually are very, very robust to all of these variables.
Great, thanks. And with Paige, you can deploy anatomy by anatomy or scanner by scanner. So if you are to start a place where the return on investment or the outcome for patients or workload is the best, which area anatomy will you recommend to start?
Yeah, so I would say that certainly from the biomarker area, perhaps our two most robust models would be HER2 complete as well as colon MSI. So I would say that those are perhaps our two most robust models from the molecular point of view. But of course, bear in mind that, from the clinical point of view, in terms of the detection of cancer, certainly I would say that prostate continues to be, the one and only model that has got FDA clearance in the US. And, this is something that was gained over a couple of years ago. And to date, no other model has achieved this, has cleared this very exigent benchmark. So I would say that's certainly, the other area in which this AI model seems to excel.
Also read somewhere that for the breast lymph node, you had the breakthrough designation from FDA. Is that still the case, or where is that now?
Indeed. So this is something that we gained late last year. And this is something that, again, we are chasing for full clearance. So it is something that it is in the works. So, of course, watch this space.
Great. And then one comment or question from Maxim here. He's saying probably we'll also need a new terminology for HER2 test result. As for now, positive, negative, what is used based on amplified, non-amplified status? What's your reflection here?
So yeah, bear in mind that the paradigm that we follow was using the AI as a binary detector. So I think in principle that would be consistent with the evidence that we have so far. So in other words, a subgroup of patients, do not have sufficient mRNA to actually render them in principle responsive to the new therapeutic agents, whereas another subgroup of these patients would be. So I think in principle, this binary classification would start to make sense.
Great. Maybe a final question for me. If you are a pathologist working here and you introduce the biomarkers, how will you see your daily work or routines change? How will it impact your daily work as a pathologist with biomarkers?
Yes. So I would say that, still very early days for this technology to, to start changing current practice. But of course, we all have to start somewhere. And the idea would be to deploy these tools in parallel to current standard practice and see how good a job they do prospectively. We all know that things in vitro do not always, and in silico, do not always work as well as, they actually seem when they're applied in routine clinical practice prospectively. But this is, I would say, the next step for these tools. So to gain better insights, better experience in forward clinical validations and see how good they meet their mettle, basically.
Great. I think no other question in the chat here. Any final comment from you, Juan, here before we wrap up?
No, so just to say that I think, it sounds a bit like a topic that, pathology is going through the third revolution. Obviously, the first revolution was immunostaining in the 80s, molecular in the 2010s, and artificial intelligence in the 2020s and beyond. But I think it's actually increasingly true, and we have increasing evidence to support, a whole change in paradigm of how these new tools actually can help pathologists do a better job and better classify our patients. So very exciting times to be a pathologist indeed.
Yeah, I fully agree. And listening to this, I think we're in for a step change within digital pathology with the big benefit both for the patient outcomes and the workload for the organizations here. So thank you all for joining. The ambition was to bring in a bit new perspective and inspiration this time around digital pathology, and a few more sessions will come in around digital pathology later in the summer here. So please sign up and you will get the invitation, and we'll also upload this recorded version within the next few days. But thank you everybody for joining and for you, Juan, to share this very interesting with all of us. Have a good day, and thanks for joining.
Absolute pleasure. Thank you very much for the invitation, Ulrich. And thanks all for your attention. Bye-bye.